Exatamente. Nas décadas de 80 e de 90, seguiu o modelo das reformas
In
voltadas
the
para
80s,
eficiência,
we
efetividade,
started
equilíbrio
following the
econômico
models
e
of
qualidade
economic
da atenção.
balance, quality, and attention. Now, with digital health, Sweden has been investing in organizational models, infrastructure, and human resources so that they can have tools that provide expansion of health and access to the whole population. The CEO of the first Swedish hospital to be privatized, Peter Holm, will be with us today, and he's going to talk about the governance model of health in Sweden. In addition, we have Ary Ribeiro, CEO of Hospital Sabará. As a moderator, we have Nelson Teich, former Ministry of Health, and federal representative Congressman Luizinho from Rio de Janeiro. So the room is Assim, Saúde, health in Sweden and its governance model. Well, good afternoon, everyone. I'm delighted to be here with you. I would like to start by thanking the organizing committee, the organizing of Digital Fest, my dear friend Josie Avila. And let me reinforce the importance of this event where we bring together ideas, all of us contributing to the development and improvement of healthcare system in Brazil. The topic we are going to discuss today, as we've heard from the opening remarks, is healthcare in Sweden and some aspects of management and governance. What we are going to address, in addition to a general understanding of healthcare in Sweden, are some specific aspects of an experience which I think is quite interesting: public-private relationship in Sweden. To do that, we have the pleasure to welcome today Peter Holm. He is a physician from Karolinska Institute. He had his very robust medical scientific training by Institute Karolinska. Peter has a very interesting PhD thesis about pulmonary circulation and vasoconstriction and an endothelin role. Peter is a chest surgeon, cardiac and chest surgeon, and we worked together in the 90s, which was my pleasure. And after a fantastic medical scientific career with the medical hospital and the University Hospital of Uppsala, and also in Australia, Peter changed and started working in management. Since 2010, he started his training in management, and for the past 5 years, he joined the largest organization of service provision in Sweden, which is CAP. And recently, he took over the role of CEO of St. Göran Hospital. And Peter has a very interesting experience to share with us of managing a hospital, which was the first hospital in the 90s to join this new kind of service provision, which was a public funding provided services through a private entity. And here we also have the great pleasure of welcoming Nelson Teich, former Ministry of Health, a brilliant oncologist, also a very successful entrepreneur, someone who has very broad mind and ideas about how healthcare systems should progress and develop. And I'm sure Nelson is going to bring very interesting inputs thanks to his great experience. But finally, but not least important, Luizinho. Luizinho is an orthopedic surgeon by training. He has great experience in health management because he was health secretary of the Department of Health in the state of Rio de Janeiro. And currently he's a congressman in Brazil, and he always brings positive aspects to the agenda of health in Brazil. So I'm sure this is going to be a very interesting panel. So we are going to do the following. Peter is going to just start by sharing his thoughts at about 20 something minutes, giving us a general overview of healthcare in Sweden and also the public-private relationship in Sweden. And then we are going to open for comments by our two guests. So if they could maybe stick to 5-10 minute comments so that we can open for questions and for further interaction, and questions can always be sent to us through WhatsApp. And by doing that, we are going to stick to our time. So, Peter, back to you, please.
Thank you, Ary, and thank you for the organizers to have this opportunity to talk a bit about the Swedish model, and always good to see you again, Ary. Well, I'd like to start with some facts on the country. Sweden has a population of 10 million, and it is not densely populated. The standard of living is good. We rank around number 15 of the world's countries in GDP per capita. A rough measure on health status could be average life expectancy, which is roughly 82.5 years. Another measure is infant mortality, which is down to 2.5 per 1,000 births, and that's one of the lowest in the world. To evaluate healthcare, there are different healthcare rankings, where Sweden comes out as around number 15 among the world countries. Now, what about governance? Swedish healthcare is organized in a decentralized way. 21 regions are responsible for the healthcare at hospitals and local health centers, whereas 290 municipalities are responsible for elderly care and social assistance. For example, Stockholm and neighboring suburbs are smaller cities. It constitutes one region. In that region, there are 26 municipalities. The central government, or the Swedish national state, is to establish principles and guidelines for healthcare, but the execution or provision of the care is made by the regions. Thus, we have 3 levels of decision-making assemblies that are all governed by politicians elected every 4th year. One moment. Swedish policy states that every region must provide residents with good quality health and medical care and work to promote good health for the entire population. A very strong policy intention is to have equal access to healthcare for all citizens. Now, looking at finance, Sweden has overall high taxes. We are among the top 5 countries in the world when it comes to taxation. Considerable part of this is allocated to healthcare. We spend around 11% of GDP on healthcare, which is roughly 2.1 percentage points higher than the OECD average. Almost all of these 11% is collected by the regions through taxes. The central government has an impact on financing also, since there's a redistribution system where money from wealthy regions, notably the capital region of Stockholm, is allocated to other less wealthy regions. The central government can also finance the regions in certain health policy areas, such as reducing waiting lists. However, most of the financing is by regional taxation. Now, looking at organization or delivering the care, that's up to the regions. So they can provide the care using their own organization, hospitals, etc. This is by far the most common way of providing care. 85% of the care in the country is provided by the regions themselves. They run university hospitals, they run tertiary and secondary care, like local and regional hospitals, and most of the primary care. However, the regions can also use subcontractors, such as private healthcare companies or non-profit actors. The private sector runs roughly 15% of the total healthcare. The private sector share is lower in specialized medicine, where it's around 8%, but higher in primary care, where it is 40%. When a region wants to outsource care to the private sector, they can use two types of deals with the private providers. One is care contract, where there is a bidding process for the care contract, which is defined in what type of care, the length and the volume in the contract. Private companies can then compete for the contract, and one winner is then assigned the mission or the care. The contract for my hospital, Capio St, is the largest single contract in the country. We are the only private provider running a tertiary emergency hospitals. The other type of deal is called care choice, where the regions define the medical area and certain criteria a provider must meet to deliver the care. Price is also given by the region. If a private enterprise or private company meet these criteria, they are authorized and can start recruiting patients. Care choice is meant to give patients a choice between caregivers and hospitals, and for the private providers to have reasonably long-term stable market conditions. It's up to the region to decide if they want to subcontract care using care contracts or care choice. However, primary care is an exception since there's a nationwide care choice decided by the central government. That could in part explain that the share of private providers, 40%, is much higher in primary care compared to other medical fields. The overall structure of the healthcare has a history of being oriented around hospitals. I think this is partly explained by the politics in the 1960s and 70s that made local GPs, general practitioners, that used to be independent practitioners to instead become employed doctors in the hospitals. The overall trend of shifting inpatient to outpatient care has resulted in a clear reduction in the number of hospitals beds, now down to 2.2 per 1,000 inhabitants, one of the world's lowest. For example, most of the mental care is now in an outpatient setting. There's also a clear ambition by the central government and regions to expand the primary care. Most of the primary care is done in GP stations, where a group of employed practitioners provide primary care for the population. They are financed from the regions by a mixture of pay per service, doctor's visit, and etc., and capitation pay. The trend is clearly towards more capitation pay, where a patient can choose their GP station that is then being paid a yearly capitation sum by the region. That part of the reimbursement is the same, regardless of how many visits the patient has, and is aimed to promote prevention and maintaining health. Now, if I may, some reflection on how all this works. Being a country with a high standard of living and with an ambitious welfare state, our healthcare is performing reasonably well. However, like all care models, we have some problem areas. One is accessibility. Waiting lists can be long in many areas. That goes for specialized medicine, for example, planned surgery, but also sometimes to get an appointment with your local GP. I think part of that problem is because productivity could be higher. I mentioned that we score around place 15 in overall healthcare rankings, but in terms of efficacy, we score lower, around number 25. A Swedish doctor sees on average fewer patients than in most countries. And one explanation to this could be low incentives for doctors that are mostly employed by the regions. Another explanation is low competition, where the regions not only pay for most of the care, but also provide the care by their own organizations, hospital, etc. So I think that the growth of the private sector is a result of the effort to increase competition and productivity. The private sector has grown faster than the public sector the last 7 years. Private care that is financed by the region has been promoted by the conservative and the center political parties. However, also the social democrats have accepted large parts of the private sector, although they remain more skeptical. Social democrats also seem to use care contract where the region has more control over the time period and overall cost. The center and conservative parties prefers to care choice, which can be used for longer periods and encourages patients' own choice. Care choice is proven to be an efficient way to expand capacity and reduce waiting lists. Another problem is continuity. When I worked in Australia, my experience was that doctors in a consultant-based system were very much identified as the decision maker by the patient and the system. In Sweden, there's more of a team approach where the department has a more or less collective responsibility for the patient. Also, the GP's role is weaker in our system. The patient is usually listed to a general practitioner, but as soon as the patient is referred to a specialist, the GP's involvement becomes weaker and patient often experience a lack of coordination of the complete care. As many countries who also struggle with how a health care system can renew itself. We have an aging population and there are challenges in sustaining healthcare costs and still providing a service. Of the many trends affecting healthcare, the system has been successful in some areas. Expensive inpatient care has been transformed to less expensive outpatient care. Also, length of stay in hospital has been successfully shortened. The rapid increase in cost for pharmaceuticals has been mitigated by coordinated efforts by the regions. The regions, they have a big negotiation power when it comes to pricing of pharmaceuticals and also medical devices. Overall quality of care has also been improved by the many and comprehensive national registries that covers most of the medical fields. The registers provide feedback to the providers and to the payers on the quality of the care. Our other trends, however, are more problematic to handle. The healthcare system is, as I described, a bit fragmented. This can lead to unnecessary hospital admissions and expensive care. The system's the system's ability to predict and prevent expensive care will probably need to be developed further. A clear trend is also digitalization of healthcare that is affecting us all. Sweden is a fairly internet and tech-savvy country. Digital healthcare by visits to doctor by video or chat has really taken off the last 2 years. Some new private companies have gained a strong market position. They use 24/7 access to increase their digital visits and use this to have the patients listed with them. That has had the effect that the existing GP stations that provide physical care has lost patients, and that patients remaining with the physical GP stations are older. Those patients are older and sicker since the digital players seem to attract younger, more healthy individuals. My company, Capio, is aiming to provide both care both digitally and in person at GP stations. And also, if I may like to finish with some personal view on how healthcare possibly could improve. First, I think a separation of the roles of the payer and the provider is essential. The region has tried to do that where one arm of their admission is ordering and paying for their care, whereas other arm is organizing the provision or the execution of the care in hospitals, etc. However, that separation has tended to be weak. Public hospitals that are less efficient and not performing well have not been duly challenged. Second, I believe that an expanded capitation model is attractive. The region can then, as payer, outsource the care to a provider in, for example, an area like a suburb. payment should be based on capitation, not only for primary care, but also for specialist care. This would give a provider, a private company or a regional provider incentive for preventive care and care at an optimal level, avoiding unnecessary hospital visits. I think there are some interesting examples of this, like the NUCA system in Alaska and also the ChenMed system in Texas. Thirdly, I think it is obvious that the political system should have a big influence on a country's system for healthcare. However, healthcare is like most sectors. In healthcare, it's like most sectors. Planning and stable conditions are good. As a private provider, this is perhaps more important. As a private company, we want to attract investments, etc., to be able to develop the hospitals or the healthcare service. For example, in digital care. For that, we need some sort of a stability. Here we have elections every 4th year where the political parties tend to have differing views on which way the sector should go. In a system like ours with the huge dominance, not only of public payment, but also public provision, political controversy can be a problem. I'm not an expert, but I think that financing through mandatory health insurance, like in the Netherlands, could be an interesting model. Thank you for your attention.
Bom, Peter, muito obrigado pela sua explicação, pela sua explanação. Eu acho que você, no meu entendimento, você abordou todos os pontos.
All the key points which are relevant, both in the overall perspective as well as in specific aspects in the private-public relationship in the healthcare system. And I believe we have interesting elements for the comments from the Minister Teich and then Luizinho. So I would like to give the floor to Minister Teich and Luizinho. Probably they will take 10 to 5 minutes for their remarks. And after that, we will go deeper in some of the questions raised by Peter. And if you do not address that in your remarks, I will address them later on. Thank you. So first, Nelson, you have the floor. Your microphone is not working. Well, first, I would like to thank you, Josier, and the organizing committee for this possibility of speaking in this panel. These discussions are extremely enriching because they highlight the difficulties and drawbacks we have in these systems. When we compare ourselves to Sweden, there is a key difference between both countries. The level of inequality in Brazil is almost twofold higher than Sweden. The per capita GDP of Sweden is higher than the one of Brazil. The healthcare expenditure is extremely different, $6,000 per capita, whereas in Brazil, in this year with the current fluency, is approximately 600 for the entire policy without splitting from private and public sector. The major comment I have here is that healthcare is not only healthcare itself. It is connected with economic, educational development, inequality, everything that inserts in the reality of a country. But what I would like to stand out in Peter's talk was the difference between having the privatized healthcare system and the private initiative being part of the healthcare system in the country. These are two completely different things, and I believe this should be well defined when we discuss the systems. It's key to have a coordination approach, because when you have this coordinated approach, you'll be able to first design the proper needs and address the needs of the society, and based on that you will define the required infrastructure in terms of pieces of equipment, human resources, and optimize that. Because when you have a system, when you are not able to define the framework in charge, equipment, people, etc., it will be dealt more as a business than of healthcare. So that's dangerous. This is not a judgment of value, but that's a feature, because we talk a lot about efficiency. But in efficiency, you have a lower level of people doing more. So you have skills for the providers and for the institutions because they have better performance. And then we achieve to a critical point, in my opinion, which is to map all the service provided. When you do not have data about the people, any type of judgment is not connected to the efficiency and the quality of care. It's more related to a figure and a process of evaluation and assessment than the perception of quality. Because when you ask a person if they think that your system is good, since they do not have enough ability to judge about the delivery, morbidity, mortality rate, and without knowing the indexes and life expectancy, etc., they will judge by their own experience. So we need to differentiate how the system is evaluated by the experience of the patient and the other indexes connected with that, life expectancy, service provided, etc. So without that, you do not have the ability to understand if it's better or not. You have in the oncology system, so you have a special cancer center. If in this center you pay for the service, isolated services, chemotherapy, radiotherapy services provided, if they need to enhance production to survive and there is an arm which provides a higher level of profit, they will focus on chemotherapy. So they will sacrifice surgery, diagnostic, and training, because in the healthcare system, surgery, pieces of equipment, radiotherapy, drugs, rare and ultra-rare diseases and diagnostic methods, if you do not have a budget and guide the investments for that budget, you have a system that is not managed and is not going to evolve based on what the system have been delivering to the society. If they are not able to map efficiency, it is uncoordinated and it's not lead properly. So in Brazil, we truly should have a leadership in place, a coordination, and this should be part of the Ministry of Health Department, and this should be focused on the mapping of the daily streaming, mapping of the type of diseases, how we can create financial incentives for that. So that's my major concern. So we see innovation happening faster, at a faster pace, more expensive. So if the system does not have the proper leadership and coordination in place to define how it's going to evolve, in countries such as Brazil, with a middle income level of the population and level of inequality such as the one that we have in Brazil, the innovation that accounts it's all true when it is accessed by major part of the society, and you have a major success in the healthcare system, but this is used by only a few share of the Brazilian society. So we need to address the difficulty to access, and this requires leadership, access, and we need to stop and think how we are going to implement that in Brazil. That was my thoughts. Thank you, Nelson. Thank you very much. You provided a very interesting perspective. You addressed some aspects of difference between Sweden and Brazil. and some aspects that we can discuss further on if we have time in the value delivery role in the entire system itself. And Luizinho, I would like you for 5 to 10 minutes to make some comments, but I would like to encourage you based on the description of Pitt in Sweden and how he described the services there. Do you believe we can enhance and we can improve our current framework in place? Of course, you have a chance to speak about any topic. I was just questioning you specifically about that, but feel free to speak. And I would like to take this opportunity while we reconnect with the House of Representatives. Nelson, the minister, he raised a question which is the concept of value delivered to the patient, which is the clinical outcome and the relationship with the required amount of resources to deliver such outcome. How does this agenda works in your hospital and in Sweden as a whole? The agenda of the value delivered for the patient. Peter.
Thank you. I appreciate the remarks. I mean, I've been to Brazil, and it's a beautiful country, but I guess standard of living and inequality is different issues as compared to here in Sweden. As we come from a very government-oriented system, as I tried to describe. So the build-up of Swedish healthcare was very much through the public sector. And also, I'd like, I mean, even as a doctor, you have to be humble. Healthcare is just part of health. I mean, sanitary conditions, plumbing, and etc. Housing means of course a lot for any nation. But anyways, we come from a very public-oriented system, and the privatization has been from a fairly high level. And I think in our system, the value for the patient is through more efficient care, and to have bias in the reimbursement or to do the right things. That's of course really important. But I think in that context, our registries and the sort of data-driven evaluation of the care that we provide is really important. And I think the digital revolution in general will provide many countries to have access to proper data. How well is the region, public or private provider really performing? And also, as you mentioned, it's really hard for the patient to evaluate the sort of care. There's an information gap between the provider and the patient, but in part, I think that the data could be helpful. And here it's like for me as a private provider, the region is sort of the patient's agent. So the region helps the patient to evaluate, do we do the right thing at my hospital? Do we have the right quality? Do we do the right things? And that is being evaluating using data registries all the time. And that's, I think, a value added to the patient, but also to the whole system.
Muito obrigado, Peter.
Thank you very much, Peter. Now I would like to give the floor to the House of Representatives, Luizinho. Can you hear me? Yes, we are now connected. We can hear you loud and clear. Thank you. I would like to thank Josiah for his invitation and the chance to participate here with Peter, with the Minister of Nelson Teich, which has skills and competence which are really key for our country. Talking about inequalities between Brazil and Sweden, I would like to highlight that Brazil is evolving inexorably to use, in terms of hospital setting, more private sector services. We have a primary care network which is strengthened by the public healthcare system, but the public accounts makes this private service provision the only way to expand the healthcare system in the country. There is no other way out. We have a gap in the primary healthcare. Although we have the security reform, it shows that both the federal impact at the city and municipality levels is really key, and we need to expand the healthcare systems in order to improve governance and the final outcome for the patients, not only the clinical outcomes, because Brazil faces today a need of good clinical outcomes, but we need also some type of outcome. We have some gaps at the healthcare system in many regions. We have people waiting in a waiting list for 3 to 4 years to simple surgeries like herniation surgeries and gallbladder surgeries. I worked for many years in this field. In the past, maybe 30 years ago, we had key private service providers, charitable institutions. We had the Santa Casa and we had SUS, connected hospitals, and we had a 4x7 systems, and they would receive the payments directly from the federal government. This system was disrupted, and we have some service rendered that is not connected to the merit of the service provided itself. The pricing of the public healthcare system is very low, and depending on the high complexity and middle complexity, this payment is not made by service itself. So we do not have another way out unless we expand the private service provided in healthcare system. And we had the service rendered by social associations and the public healthcare services. We have good models in place, but most of them have a lot of issues. I have been advocating that even the public healthcare hospitals could be managed by private companies with consolidated profit and the amount of the agreement at the end of the day. So we cannot live under the scope of social associations that are disguised as a private group. So the bad healthcare available and the level of procedures delivered is lower than the private hospital setting. So the unit service provided is lower than in the other private hospitals. Per surgery, per patient, for clinical outcome, we pay more in the highest cost hospital here in Rio de Janeiro and with the public healthcare system level. So there is a major difference between Sweden and Brazil, but we need to have a different perspective towards the private rendering system, and we can understand that better and be able to measure properly. The Ministry of Health could understand the metrics of the quality of service. Since you have a very poor clinical outcome, we pay very low for that. But if it is not good, you pay more for a hospital stay and ICU, improper performed surgery for unskilled professionals. So Brazil has issues of skills, and also we do not have proper procedures established. We do not understand the roles of the state level, of the municipalities level, and we do not have implemented a hierarchical system for services provided. We could see that the waiting lists, that they are available in Sweden, and it's not different from what we have here in Brazil. We have a waiting list, but the waiting list here, the patient here, has a higher level of anxiety because they can have a drug treatment that is very expensive and is not covered. But in the Sweden service, they find a solution, which is the private services provided at the public level. And so when they have a bid, they can analyze that properly and render the service, because the way we are providing services here in Brazil, basically in the moment we have a specialized care, we require special testing, high complexity tests in the middle term, and that's a major bottleneck. So we have some quality, but in high complex services provided, we have a true bottleneck here. And we have differences in Brazil, between Brazil and Sweden in this sense, and they are huge.
Thank you very much for your explanation. And it's very good to hear what you have been advocating in the Congress, how to act so that we can provide better access. This is something absolutely essential. I think we have to discuss less who is going to provide service and discuss more how people can have access and what is ultimately delivered once access is granted. We have about 8 minutes, and I would like to start by giving the floor back to Dr. Teich to tell us what is the key message, the main take-home message in terms of what we've heard, because this is the purpose of this conference, isn't it? Talking about improvement to our healthcare system. Sorry, cannot hear you. Well, I would like to thank Congressman Luizinho for his kind remarks. Some regulations that can be enforceable, that can be practical to the society. Because sometimes when you design and you think something in paper, paper takes it all. It sounds perfect. But our main barrier is how to enforce it, execute it. And I think one of the main barriers is funding. Things are not either good or bad. They are well used or not well used. So it doesn't matter if it's a private or public provider. We just need a good one, an efficient one. But we need a centralized coordination. This is something we have to improve. But our main concern and consideration is how can we pay back private entity? Maybe we should have fewer to provide better compensation. And let me share with you some numbers comparing to Sweden. Sweden, without, of course, checking the update, it spends $6,000 per person per year to spend in terms of healthcare. In the Brazilian healthcare system, we spend $400 to spend per person per year, considering federal, state, and local government. So in our situation, in our level of efficiency, of how we allocate resources, how we define financial incentives, and how we control appropriately service provision to make sure that they deliver good services of quality. We have to have better monitoring systems. And this is a journey, isn't it? Our Congressman, Luizinho, is someone who is going to focus on it, and people such as him are essential to ensure our progression and our improvement. But you see, these are all key points. So funding and control and management. But of course, we have more complicated financial situation. Being a mid-sized country, and our fundings are much more limited. Congress Luizinho, I would like to ask you just to close your, just draw your conclusions for 2 minutes before we can hand it over back to Peter. So what was the key message? What is useful as take-home message for your discussions in the Congress for improvement of the Brazilian healthcare system? Well, Ary, based on Peter's presentation to us, first we heard the difficulty of continuity and all the political changes that impact that continuity, something we experience in Brazil as well. I don't think we should vote autonomy of the central bank in Brazil, but rather autonomy of the Ministry of Health and Ministry of Education, because only if we had autonomy and continuity policies, we would be able to deliver things. Because I'd rather have a Ministry of Health being able to provide long-term public policies than Brazilian Central Bank. I don't care about the central bank. There is nothing new to invent. Everybody knows what to do about economy. But in health and education, we need that continuity to really develop appropriate training and deliver results. This is why I advocate for autonomy of the Ministry of Health and Education. Another difficulty that we see, another thing that, I'm back here. Another thing that I observe in Brazil is the quality of our spending, so to speak. Of the $400 that we have per capita, we are spending over $200 just with red tape. Just red tape. Red tape is sucking up the money of health. So because of bureaucracy, our patients are not better treated. Less than half of these expenditures is getting effectively to healthcare provision. And this is why I think it's important to be part of this discussion, why it's important to talk about new models of governance. This is why it's important to have a stronger action of the private sector. I think we have to reduce bureaucracy of health, delivering better care. I say when I was a state secretary of health, it was a city of 900,000 inhabitants. When I got to a station, for example, a healthcare center, there was AC and there was a telephone working fine in the office of the director, never in the doctor's office. And I don't care about the director's office. I care for the appropriate care delivered to the people. And this is why listening to Peter and the importance of having private, effective provision of care in the country. It's not going to be fast, but we need long-term effect. And I'm sorry if I was not very technologically savvy here. No, it was fine. We could follow you perfectly. Thank you. Now, Peter, I would like to give you some more minutes for your closing remarks before I close. So now back to you, and I hope this opportunity of exchange of opinions and listening to very important players in Brazil in terms of solutions and recommendations has also been useful for your own journey and experience. So your final considerations, please.
Absolutely, a lot of good remarks and also a very prominent panel I'm learning a lot. I think a pragmatic approach is really, really good. Healthcare policies tend to have a left side or right side, conservative side. A pragmatic approach is I think it's beneficial for the sector, and also to lay out the framework, the ruling. One example is we have care at 3 levels, as I described, or 3 decision levels. Most of the regions, the municipalities, they have nursing homes, but they are not allowed to employ doctors. So the regions, they have more or less a monopoly of the doctors in the public sector, and that's a sort of a clear-cut division of who takes care of what, which I think has been good. Also, the market. I'm a big representative for a big company, comparatively big company in Sweden, but I think bigger players seems to be more stable. I think the misuse of the system we have had here in Sweden has been very much attributed to the smaller players, and all you touch upon the data-driven decision making to have the a clear base for how is the quality of care delivered. And I think that in many countries that will be more easy in the future with the digitalization coming in. So yeah, that was what I picked up from the discussion.
Thank you very much. With that, let me once again thank you for your time and for your generosity to share with us your experience. Of course, we could go on and on discussing for a long time, but we had a definite time slot. I would like to thank former Minister Nelson Teich for his generosity and time, for coming and sharing with us all his vision, and also Congressman Luizinho, someone who has been a role model, someone who is absolutely instrumental in our Congress, someone who is really helping us improve the healthcare system. And once again, let me greet and thank the organizing committee for opening this opportunity, discussing this possibility based on a new model, which is not, of course, immediately reproducible in Brazil, but its experience and its ideas can definitely be adapted. Thank you very much, everyone. Have a good day and enjoy the event. Thank you. Thank you.